Well, hello. This is Dr. Isabelle Amig, and welcome to the Unabridged MD podcast. Here we explore inspiring stories, practical tools, and expert insights for living a healthy life. Whether you're a patient, a healthcare professional, or simply curious about healing, you are in the right place. And as always, if you are looking for something that's so much bigger than just a rheumatology practice, please come check Unabridged MD, as we are the right place to get you to remission with the least amount of medication. With that said, let's dive in. Well, hello. So today is a little bit different than usual. What I wanted to do is, Marta is a friend of my sister who lives in Berlin, in Germany. And she has a lot of questions about possibly rheumatoid arthritis. And a lot of those questions are really, really good. And I have a tendency to hear them often. And so I thought that we're going to use the question of Marta, whom I'm just meeting, and we're going to basically help everyone understand about rheumatoid arthritis, about just inflammatory arthritis. You're going to learn as Marta is learning. Okay? So Marta, tell me, what's going on? How can I help you?
Yeah, I was diagnosed rheumatologist arthritis this summer, the end of summer, and yeah, I think I don't know if this just appears like that or it's a process. I thought because I had the menopause a few years ago, and I noticed that I had some pain, but it was specific. Sometimes on the back, sometimes especially on the back. And then my knees started to hurt. And when I went to the gynecologist, she said that possibly the menopause and I was low on hormones. Mm-hmm. So she gave me some hormones to take, which I'm still taking. The beginning was really just 0.5 milligrams. So it's the minimum amount of hormones, but that helped. And then when that helped with the pain that I was experiencing sporadically on my knees or my back. And just 2 years ago or a year and a half ago, I went again because the pain kind of went a bit more. And then she said, well, probably it's such a small dose. And she gave me a 1 milligram of the hormones. And it went a little bit better, but this summer it was quite stressful. And somehow, one day I started to feel pains all over the joints. So I just thought that was a bit different than what I experienced before. So after a couple of weeks or something, then I went to the rheumatologist, and she diagnosed me the arthritis. So and then I just didn't know anything about this. I wasn't.
Can I not? There's a lot that I want to unpack here. So you underwent. So you're basically going. Is it menopause or is it perimenopause?
No, I already am in menopause.
Okay, so you have a lot of. Go ahead. Sorry, excuse me.
No, I'm saying I'm 53, so it's kind of the time.
Young. You look so much younger.
And I suppose this arthritis. I just then started to research a little bit what was it, and I thought it was some that this might arrive much later in life. But then I realized that it was also a combo because it was an autoimmune disease. It was a combo of things, of factors that maybe.
I want to backtrack a little bit because you have mentioned back pain. So first, you're 53. You're a woman. Do you have any family history of autoimmune, like rheumatoid arthritis, lupus, any inflammatory back pain, anything, or like a GI?
My mother.
What does she have?
And my father actually, maybe as well. Actually,
what do they have?
I don't know exactly the diagnosis they have. And my mother, I do. It's the reuma, but the osteoporosis. Is it possible when the bones are starting to
fragile? So that's osteoporosis. Okay.
Yes.
But that's not arthritis. That's a bone issue, which is different than inflammatory arthritis. Do they have?
My father more bad. My father had the fingers, always a problem. Even he was operated at some point of the tendons, and I think he still kind of takes some medication, but with other things, I suppose.
Got it. Is it inflammatory? Is it something where, so now the question I have for you, you mentioned the back. Where in the back do you have pain? And do you still have pain?
In the lower back, it's my lower back, yes. And I remember once I was just like cleaning a little bit, the organizing the room of my son, and then I couldn't move. I hold something from the floor, and I couldn't move. I was stuck with the back, but that was a few years ago already. It didn't happen again. Yeah.
Okay.
I had to take a taxi and go somewhere to give me a shot of something because I couldn't move very well.
Yeah.
But that was one time, and that's why then I went to I went to the other doctors because I didn't know, and then I went to the gynecologist just by chance, by something else, and then I mentioned this, and plus the knees, that I was starting to hurt my knees, and she said, yeah, maybe you need some hormones, some treatment.
Mm-hmm. And that's absolutely true. So menopause, postmenopause, perimenopause, like, all of the hormone changes, you can have joint pain. So absolutely true. But it is interesting. So it's more of a mechanical pain, the back. Is it worse at the end of the day, or is it worse in the morning?
At the end of the day, it's a bit worse, but now the back, I notice much more the other joints. For example, my hands, my fingers, even my ankles, on the foot.
So let's talk now about those. Let's talk about those. Okay. So you have pain. Is it symmetric? Is it both sides?
It's not symmetric, but I have pain in both sides. But it's not symmetric. It's not. So, for example, my wrist, it's more on the left today, and my right one is fine. But a couple of fingers on my right hand also a bit painful.
Okay.
And I'm taking medicine for this now. Yeah, I'm taking medicine. I started end of August to take this
hydroxychloroquine. Yeah, Plaquenil. Hydroxychloroquine. Yeah, it's an anti-malarial drug, and what's cool about that drug is that it's not immunosuppressive. So that's very cool because it's very mild. Now, but I do need to know more about this. So the joint pain you have, it's so you said your wrist, your shoulders, your ankle, your feet, your knees. Does it involve the MCP, the PIP, and also the DIPs, or only the MCPs and the PIPs?
Yeah, these two.
Those two. So that's the top is spared. That doesn't get involved, correct?
Well, the pain is now that I touch it, maybe.
Got it.
Now that I touch on the table, I'm doing like this. Maybe it's a bit painful, yeah.
Got it. Okay. It's important because we don't know yet, right? Like we don't know, we are not sure of what it is, right? Yet. And then the pain that you have, is it worse in the morning?
Yeah, I would say in the morning before the medicine, yeah.
Okay. And do you feel like you have morning stiffness? So do you feel like you have to do this for more than 30 minutes in the morning?
Well, I have pain. I don't know if I have stiffness. So I can move my hand, no? But it's a bit inflamed and it's painful. Stiffness, like I cannot move, you mean, yeah? That I cannot move.
Well, like, stiffness, I'm feeling like, oh, I have to do this. Like very often my patients, they'll tell me.
Yes. This I have to do, yes. And sometimes because the pill is inflamed, my fingers are inflamed, and so I just can do this, for example, not this,
Got it. So you do feel that. And so how long does it last, this stiffness in the morning?
I don't, I didn't calculate it so well, but I would say a good couple of hours.
Yeah. So, okay. So you have a couple of hours of that. And do you have any swelling of the joint? Swelling where
yes.
Like it's...
Yes. Sometimes the swell is a bit swollen. Yes. A bit less now with the medicine. Yeah.
Yeah.
Less.
Yeah.
It used to be more inflamed than it used to be. a bit more. I mean, I still have it a little bit, but
Yeah.
like
So
a pain that
since the
I can take
summer,
right now with the
August,
medicine.
yeah, and August to now,
End
that's
August. End.
end of August to end of December, that's 4 months, right? So you have had, like, now you have had the full effect of Plaquenil. So hydroxychloroquine. So now, okay, so now I just want to have a little bit of a question, which is, do you have any psoriasis? It's a skin rash that we can have in the hair, on the scalp, in the ears, on the belly button. Sometimes it's in here on your elbows or knees. Do you have any flaky rash like this?
No.
Okay. And do you have any changes of your nails?
Changes? What do you mean? That like they change?
Yeah, like normally nails are pretty smooth. Do you have any like splitting or points in it? Like, is it punctuated? No?
No.
Okay. Okay, perfect. Cool. So basically, when as a rheumatologist, what the first thing always that I do is I make sure that we are in the right place. Like, is this really rheumatoid arthritis? And when you mentioned you had back pain is usually not associated with rheumatoid
No.
arthritis,
And it
right?
happened once, and now it's kind of, I wouldn't say I have back pain like
Exactly.
that. It's more the it's more the joints of my body.
The peripheral joints, yeah. So
Yeah.
good. That's what we want to decipher as a rheumatologist. So I agree. I think it sounds like more peripheral. So we say axial is the spine and the thorax, the thoracic spine and all this. That's axial. The rest is peripheral. There is involvement of the spine. It's the cervical spine with rheumatoid arthritis, but it's usually when people have very severe rheumatoid arthritis, and it's most often when we haven't taken care of it. So it doesn't sound like you. Okay, now, did you have blood work, and did they check the rheumatoid factor and the CCP? Do you
The
know?
blood.
Yeah, the blood. Did
The
they
blood,
find
I have some
like,
blood
yeah,
result. Actually, then when I went to the rheumatologist, they started to take blood every 2 weeks, sometimes 3 weeks. But yeah, it's been
okay.
regular.
Okay, and in that blood, the first one, do you
Oh,
remember?
hold on. Then I have to go and have a look at the paper.
Yeah, no, that's awesome. I love it.
Yes. Yeah, hold on, because I do keep them. Would it be the first one or the latest? The latest one.
It's the first one. We usually, as rheumatologists, we do more blood work at the first one, just because we're like wondering what it is. And we can still make a diagnosis of rheumatoid arthritis without blood. But the blood tells us if it's going to be worse, like if you need more medication or not.
Yes, hold on. Let's have a look.
So what I'm looking for is the rheumatoid factor and the CCP. And I can translate that. CCP in German would be called...
Well, thanks again for tuning into the Unabridged MD podcast. Be sure to subscribe so you can be notified when the next episode is up. And as always, if
so
you
let's
think
see
that
if
this would be helpful
it would
for
be
a friend or family member, please share.
CCP.
Wishing you wellness. Until next time, take care.
Now is that I should have prepared this bit before.
That's okay, don't worry. No worries. And if that's okay. If maybe your rheumatologist told you, maybe they didn't tell you.
API. CCP, you said.
Yes. And in German, it seems like it's called CCPAK, but also rheumatoid factor. If you can find a rheumatoid factor, I would take that as well.
No, I can't see it, unfortunately.
That's okay. All right. That's okay. And you can always tell me later on. And this happens very often, right? Like they probably have done it. I would imagine that they have done it. But again,
thing like this, but I'm not.
You can send that to me if you want. Send me pictures of all of them and I will look at them. Okay.
Yeah.
All right. So,
yes.
And so, okay, so it's possible that you do have rheumatoid arthritis because of the way it's presenting. So it's, when we change hormones, so very often it's after, it's not all the time like this, but I have to tell you as a rheumatologist, and I've been doing this for almost 30 years, a little bit, almost more than now. And what I have found is that in the changes of hormones, so someone will be pregnant, and after pregnancy, and I don't know if you know this, but after pregnancy, our hormones drop, and we're actually technically almost like if we were in menopause, right? And so very often, if women are stopping breastfeeding, they'll develop some joint pain, and like ultimately we make a diagnosis of rheumatoid arthritis, and around the perimenopause and postmenopausal time. So there is definitely an association between the changes of hormones and the beginning of rheumatoid arthritis. The other thing is rheumatoid arthritis. So it's an inflammatory arthritis. So it's worse in the morning. It's associated with morning stiffness. There can be swelling of the joint. And it's usually symmetric. So when we say symmetric, it may not exactly be both sides, but it usually affects both sides. And it spares that. It spares the DIP. The thing that's a little tricky is sometimes you can have rheumatoid arthritis and osteoarthritis. So you can have the rheumatoid arthritis, that's usually in the morning, right? And the osteoarthritis will be more towards the end of the day, okay? So just know that it is a possibility. Now, ask me all of your questions, because clearly, like the reason my sister shared my contact is that you are really afraid, you have a lot of fears, and I want to reassure you, and in the process, I want to reassure anyone that would potentially watch this video, okay? Because the reason I'm such an optimistic physician is that I'm a rheumatologist. Rheumatology is like the best specialty on earth because we have incredible outcome in our patients, right? So ask me all of the questions.
So for me, also, I believe the body functions holistically, and I just found that the rheumatologists or the doctors that I found, or that I, let's say, landed, it's very straight rheumatologist, and she so says that I need to take the drugs, and also I had cortisone for a few months because it was quite painful. And now, for example, I still take half. Sometimes if I'm still feeling very, very painful, I have half every 2 days of cortisone. And I need to see her in a month, and hopefully that I can take away this half cortisone every 2 days or something, or even sometimes, it depends how bad it is. Then I take this in the morning too. And for me, the question was, the causes of this, that could be genetic, that you said, the menopause, that could be a stressful life, not much sleep. And when I say stress of life, it's because I'm an artist, and also it's not easy, and I'm a mother. It's not easy to, let's say, survive as it is. So I need an extra job. Living in Germany, I'm not German. There's lots of aspects that maybe then, you get stressed. And I thought the stress was a possibly main big factor too. I don't know. She couldn't say, she couldn't say. She just said it was genetic. And she wouldn't know. And then I said, what about, how would it be possible to resist this? Because if it's an autoimmune, that means that hopefully maybe if by changing the mindset, trying to reduce the stress, maybe doing something about the food, the not just the quality, but how, which kind of, how to say, diet. I say it in German. Yeah, you want to pass?
Well, thanks again for tuning into the Unabridged
So
MD
I'm gonna be
sure to subscribe so you can be notified when the next episode is up.
What I know about
as always,
rheumatology,
if you think
inflammatory
that this would
arthritis
be
and
helpful
rheumatoid
for
arthritis,
a friend or a family
and
member,
what you can expect.
please share.
Okay,
Wishing
so
you wellness.
number one,
Until
we
next
know
time.
that rheumatoid
Take care.
arthritis is it's an autoimmune disorder, right? So it's your body that, in response to a signal, is basically telling your cells, hey, you need to create inflammation. So the thing is, it's not your fault, right? Like and it's not your body's fault. So that's like the first thing, is like realizing that your body is doing what it thinks needs to be done. Okay. That is so important, because very often we think we've done something, right? So now the thing is, when there is a fire, and I really see inflammation as a fire. If there is a fire, you don't go with a pipette, right? So we don't go with a pipette, a little bit of water to stop the water. You're taking the Canadair, you're taking the big hose of water, and you stop the fire. If you do not do that, the problem is that it spreads, okay? Literally is the exact same thing in rheumatology. There is a signal at the beginning, and there is something that happens that triggers a reaction of your immune system. And there is something called the epitope spreading. It's basically that suddenly your body is like, okay, this needs to be a lot more. This is a normal reaction. So let's say you have infection, right? You have an infection. We need the epitope spreading because you need to have suddenly an army of immune cells that are going to fight the infection. The issue in rheumatoid arthritis is that it's a reaction against something that we don't want. This, we're like, hey, hold on, you need to calm down. Okay, so that's number one. So number one is that there's a fire and we need to put it out. Okay. And the equivalent of doing a diet change and thinking that with my diet I'm going to cure this, I have seen it. So I cannot say that I have not seen it. I have seen it in one of my friends who has a very inflammatory. When I met him, and I had met him a long time ago, but I saw him and I was like, dude, like, you have an inflammatory arthritis. I think you have psoriatic arthritis. And I was like, you've got to treat. And he was like, no, let me try diet because I have eaten horribly. I've not taken care of myself and I want to see that. And I was like, okay, fine, do this, but don't take too much time. And within a month, he changed his diet. Within a month, it was better. Who am I to say that didn't work? And he was good for another 5 years. And then again, his diet changed. He ate like a ton of sugar, and he's very sensitive. And so I'm no one to say that you cannot take care of it with a diet. But the problem is that very often when people come and see me, they've already tried the diet, right? And so and so to me, the diet is the equivalent of a pipette on a fire. Okay. So then the second thing is we have treatments, and we have super, super good treatments. Treatments. Okay. So this is super important. Treatments are only a way to help your body do what it needs to do, right? Yeah. So if you're thinking, oh my goodness, I'm taking the job of my body to heal. No, you're not. You're literally helping your body heal. So if there is a fire, you're basically telling your body, hey, hold on. Can you stop that fire? Because that is not in my highest good. You're actually causing harm right now. Okay. So this, like in general, our treatment for rheumatoid arthritis, there has been studies, there's been quite a bit of studies, actually, some in Europe, some in the US, that have shown something. We used to think, that was like in late 90s, early 2000, right? We used to think, oh, we're going to do a step-up therapy. So we're starting here, and then we're slowly going and adding this, and then we're slowly and adding this, and so on, right? So first we do the diet, then we add Plaquenil, hydroxychloroquine, then we add methotrexate, then we add sulfasalazine, right? Like, and then people were like, not really like, not sure that they wanted to like attack fast. And then we did this study where we're like, hold on, why are we waiting? There is something called, you know, a window of opportunity in rheumatoid arthritis. The earlier you treat, the fastest you get to remission, the longer that remission is going to be. Okay. And so then we did the studies where we are looking at, should we do a step-up therapy or should we act fast as soon as possible? There is a study called, I think, the SMART trial. It's been a while. I haven't looked at it because now it's like common knowledge that you have to treat very fast, very early. And that study basically looked at, we treat with methotrexate right away, methotrexate or another DMARD, right? And then we add a biologic within 3 months, right? So if I were to be your rheumatologist, I would say, okay, we start Plaquenil. I mean, if we needed prednisone at the beginning, I would probably have done methotrexate, but probably you were not really excited about it. And so your rheumatologist is just like, okay, let me start with the least amount of immunosuppression, right? But for me, I like the way I explain this to my patient is like, I'm like, hold on, like prednisone 1 has a lot more side effect than any of the other drugs. That's number one. And number two is like, the goal for us is to stop that fire as soon as possible. So you are getting to a normalcy and you can have a normal life. And the way I treat is we treat, we get you to remission, and then you back off, right? Then you back off. And I have a patient like this. She's a nurse. It's just one example. I mean, I have so many patients like this. But she was not in full remission. And I was like, let's try this drug, right? So we tried this drug and she was, you know, she was afraid. And she was like, I'm not sure I can say that I'm in remission. I'm afraid to say it. I'm afraid to say it. I mean, and then I was like, yeah, you're doing great. And then we back off. We back off the medication. She's been in remission. And now instead of a treatment every 6 months, she has a treatment every 9 months. And probably she's going to have a treatment every year, right? And then we can space it out every year and a half. And
but
so
with the same drug, you mean?
Oh, it's not Plaquenil. No, it's not hydroxychloroquine. It's another one.
Okay.
But the thing is, very often patients are afraid of drugs.
She's vestido, yeah. Sorry,
So-
my son.
No worries. So patients are afraid of drugs, but the truth is there's no reason to be afraid of drug. You have to balance the drug's safety and the rheumatoid arthritis safety. If I tell you what are the risks of rheumatoid arthritis, including on the heart, including on the vessel, you do not want this inflammation ongoing. If I tell you the risk of corticoid steroids, you're not going to want to be on steroids forever because there's a ton of risk associated with that. And then finally, then you're looking at the risk of a biologic. You'll be like, yeah, I want a biologic. I'm okay with that, right? It's okay. All right. Now I want to then respond to the stress and all this. So there are data that are undeniable about the association of our autonomic nervous system and inflammation, okay? So if you're looking at the autonomic nervous system, it's basically, there's two ways. It's the sympathetic system and the parasympathetic system. So sympathetic system is like the flight or fight. So that's like, I'm stressed out. Maybe I cannot pay for this bill. My son is, I have no idea, you know, but like my kids sometimes.
Something is like more immediate.
Exactly. It's like you're hearing a noise in the alley and it's dark. You're like, you know, and then your heart rate goes up and your breathing is fast and you're ready to either fight or flight. Okay. The thing that we forget is that you're ready to fight, flight, or you can ploof. I don't know that we say pluff, but you're like, you know, it's like, oh no, I cannot. And you're like, you cannot do anything. That's one of the issue, right? And that is not resting because the other side is rest. So fight, flight, pluff, and then rest. There is an actual other word for pluff, but hopefully you understand me.
Yes.
And then the other system is the parasympathetic system. That's the system, as a mom, you're going to understand this. It's the system where if you were to look at your son when he's sleeping, Then you're like, oh, I love this son so much because he's sleeping, he's wonderful, and he looks so peaceful. And you have this level of like, oh, you're so happy, right? That is the parasympathetic system right there that you're stimulating, okay? That system is the healing system. And so what we know from an immune system is that the sympathetic, the adrenergic system, this fight or flight system is associated with a lot of inflammation. It's pro-inflammatory, okay? So you're in this vicious circle where if your rheumatoid arthritis is not properly controlled, you're going to have more inflammation. If you have more inflammation, this adrenergic system gets really activated as well. And so you get this vicious circle, okay? On the other hand, if you're in the parasympathetic system, so you're like, resting, you're meditating, you're doing all of those things, then that actually allows you to heal. And that is anti-inflammatory, okay? So when patients are asking me, hey, am I going to be living with this forever? What I want to say is you're more at risk than anyone else, okay? But our goal is full remission. Our goal is so that you are in full remission with the least amount of medication, all right? And what I think is possible is that we get people in full remission. So again, we go fast. We don't wait. I don't start with Plaquenil because Plaquenil takes 4 months and usually it's not enough. But again, I know this because I know some patients, especially when I was in the insurance-based system and I only had, 30 minutes to see my patients. The problem is if someone is like, I don't want medication, they're like, okay, hold on. Let me first, like instead of starting with methotrexate, where you have to say, hey, you're going to need blood work. It can affect your liver. It can affect this. It can affect that. Then you're like, okay, the patient is never going to see me if I tell them that, right? So now that I have more time, I can explain, look, methotrexate, it works really well. It's actually pretty safe. The only reason we need this blood work is just to make sure, but I don't expect any problem. And then the cool thing is that if you don't respond to methotrexate, then I can go to a biologic right away. And again, if you don't tolerate the methotrexate, we can also go to a biologic right away, right? We don't wait for 3 months if you're hating the methotrexate. But then, the cool thing about methotrexate is that if it doesn't work, you can tell the insurance, in the US at least, we can tell the insurance, hey, we need a biologic, okay? And then you get the biologic, and then you get to full remission, right? And if it doesn't work, you switch the biologic. You wait 3 months, it doesn't work, you switch biologic. And again, the goal is full remission.
What is a biologic?
A biologic, okay, great question. So I wonder if I can share with you. So a biologic versus a synthetic or conventional DMARD is this. A biologic is made it is a very targeted treatment that's going to block TNF or like something like this, and it's made, and it's very often something that looks a lot like a biology, like your own cells. So it's like it looks like things, something that you could have made, right? And so sometimes actually it's even humanized. So there's a little bit human part of it. That is a biologic. A conventional DMARD is made in pharmacy. It's synthetic, and it's absolutely not something that looks like anything that is in our body. Okay. So I want to share with you a really cool image. It's not for rheumatoid arthritis, but it gives you an idea of, it's actually a really cool image. It gives us an idea of what can be done and it's for psoriatic arthritis that has actually less medications available than rheumatoid arthritis, okay? But I really love that picture so much. I'm going to share it with you. Okay, so it's this one. So if you're looking at this image, all right, what's really awesome is, attends, can you see it?
Yes.
Okay. Oh, somehow, well, it doesn't matter. So this is actually for psoriatic arthritis. It's some of the target of psoriatic arthritis. And this is the image that I show to my patients because It is so optimistic, right?
Mm-hmm.
You're going to see. It's so cool. So as you can see here, it's a cell. So it's going to be a lymphocyte. So it's a cell, an immune cell. Basically, it's going to make some signals that are pro-inflammatory. All right. And those signals are being, it's kind of like a key that goes to a keyhole. So the key is those signal goes to a receptor that's right here.
Mm-hmm.
And the key goes to a keyhole, and that then you open a door, and that door gets open and leads to a disease, usually inflammation. Again, this image is an image for psoriatic arthritis. So the signals are not exactly the same, but the concept is exactly the same. And I love this image. And again, there is more treatment option in RA than there is in psoriatic arthritis. So we're very happy. And this is very optimistic. And for RA, it's even more optimistic. But as you can see, so TNF is one of them. TNF is a very inflammatory signal. It's a cytokine. So it's a little protein that's going to basically trigger an inflammatory response. And we have receptor here on the cell. The signal goes on the cell, and then it's telling the cell to produce inflammation, and that inflammation ultimately leads to a disease. Okay. Well, we have a treatment, like we have a bunch of biologics that are anti-TNF and block that TNF. And what it does is that it blocks directly, specifically that signal.
So the question is, why don't they give this medicine?
Yeah.
No, is it more expensive or something, or what is it?
Much more expensive. But let me just finish with this. If this one, let's say the TNF inhibitors don't work, then you go to an IL-6 inhibitor, or you can go to a JAK kinase inhibitor, right? And so that's why I say, why do you want to live in pain when there is so many options actually right now for treatment of rheumatoid arthritis? Okay. Now, why we don't do this right away? Oh, actually, let me share with you. Oh, yeah. I'm going to share with you my approach to rheumatoid arthritis, which technically should be the approach of everyone. And sorry, how do I share this? Okay, so I did this when I was in my previous institution, and we help people understand how we treat rheumatoid arthritis. And as you can see here, so to make a diagnosis of rheumatoid arthritis, first you make a diagnosis of rheumatoid arthritis, okay? It's an inflammatory arthritis. It's worse in the morning. It's associated with morning stiffness. There's swelling. If it's yes, then you look for the presence of synovitis, which is inflammation of the joint. That's on exam for rheumatologists. And then you can look at erosion on X-ray and or the presence of CCP or rheumatoid fracture. If you have any of those, then you can say this is rheumatoid arthritis, okay? And then you begin DMARD therapy. As you can see, we begin with methotrexate or sulfasalazine or hydroxychloroquine or leflunomide. In Europe, we like to use hydroxychloroquine plus methotrexate, okay? So we do both in Europe. And if at 3 months this doesn't work, and
3 months.
3 months, if that doesn't work, we move on to a biologic. Doesn't work is this. So you want to reach minimal disease activity. Minimal disease activity.
What does it mean that it doesn't work? That you still have some pain or no pain whatsoever? Or
let me tell you exactly. Minimal disease activity. This is called treat to target. Minimal disease activity is defined as 5 or more of the following criteria fulfilled for at least two consecutive months. So basically, what you want is like, so look at that. Morning stiffness that's not exceeding 15 minutes, no fatigue, no joint pain, no joint tenderness, all right, on examination or pain on motion, no soft tissue swelling in the joint or the tendon sheet, and the sedimentation rate is less than 30. So basically, you are allowed to have one of those that's not fulfilled. If you have more than one of those, you are not in minimal disease activity. So when you say, what does it mean it doesn't work? It doesn't work if you have morning stiffness that's more than 15 minutes. It doesn't work if it's not working if you still have joint pain. It's not working if you need steroids, definitely not working if you need steroids. It's not working if you have some soft tissue tenderness or sweating. When you say, like, whatever you said, clearly it's not working. But also, I wasn't expecting Plaquenil to work. It's rare when it works alone. If someone needs prednisone, it's usually that Plaquenil or hydroxychloroquine is not going to work. But see, then you start and you add a TNF inhibitor, or you do a combination of DMARDs. So you do Plaquenil plus methotrexate plus sulfasalazine. In Europe, because biologics are very expensive and it's a single system payer, we ask for triple therapy before we ask for a biologic. And then the really cool thing is at 3 months, you reevaluate. Are you in minimal disease activity / remission? If you're not in minimal disease activity, you change. And then you do that every 3 months until you reach minimal disease activity. And I can tell you, usually within 6 months to 9 months, we reach minimal disease activity. Okay? That's how we do this. Okay? The thing then is to realize that very often, hello, Marco?
Oh, sorry.
Yeah, I don't know what's going on. So then yeah, I'm right here. Sorry,
hello?
maybe.
Hello?
Oh, okay, that's weird. Yeah. So once we reach the minimal disease activity, and that it's stable, so it's lasted for quite a bit of time. Okay, that can be 6 months, that can be 9 months, depending. Usually what I do with my patients, and I ask them, I'm like, okay, very often my patients are like, look, I don't want to have to live like this ever again. Leave me on this medication, right? So very often that happens, right? Some other patient will be like, okay, let's try to decrease. And so I always try to decrease, because at the end of the day, those medications, they've been evaluated in studies. And in studies, it's not the evaluation of one person, it's the evaluation of many people, right? That all look the same. And so an individual care is looking at exactly what you specifically need. And it might be that you need more, but it might also be that you need less. And so once you're in full remission, and again, you saw how, we switch fast. If at 3 months you're not in full disease minimal disease activity, we switch. Once you're there, then we can back off slowly. And we see very fast if you're someone who's gonna not be able to decrease the medication versus, okay, no, you're doing pretty good, we can decrease. You know what I mean? So the biologics, for example, I have a patient, he needs a biologic every 3 months. I have another one, she needs a biologic that normally is every 6 months. She needs it every 9 months. You don't know until you try. But the most important thing is to get full remission at first. And I don't try to decrease if you're just in, I'm doing okay, like, right? But the thing that we don't realize is that your body needs this, right? If your body is having signs of rheumatoid arthritis, your body needs help, right? So I don't know if my sister told you, but I had to deal with a cancer. And sure, I absolutely worked on doing meditation. I changed my diet. I did a lot of visualization, and I'm absolutely certain, especially after looking at some studies, I'm absolutely certain this helped the medication work for me. I'm also absolutely certain it allowed me to tolerate the medication better than any other, other medication. Like, I mean, chemo can be pretty rough, and it wasn't too rough on me, right? So you're like, oh, wow, this, like, I remember a friend saying, like, it looked like you had a flu and that's it, right? And then it's like, okay, you're like past this and you're doing so good. And I know for a fact that the stress, because I was working on all stress activities and mindful meditation and all this, I know that this helped. Okay. But I did not say no to chemo.
Yeah. So so if I go back to the rheumatologist and say, look, how long do I still need to take this cortisone, even if it's just half? She says half. It's 2.5 milligrams. She said, well, it's so minimal, it's not going to affect you so much, like the contraindications. But how long can you do that? And
that's true. And it's
also
2.5 milligram. It's milligram, right? You're talking milligram.
I suppose so. I mean, I should have a look.
Yeah, it's probably 2.5 milligram. We like to use 5 milligram and then half. And she's right. In terms of side effect, it's probably very little. But the thing is, to me, that's a sign that your rheumatoid arthritis is not fully controlled.
No.
If you need that, to me, I'm like, wait, hold on. Why would you need prednisone if you're fully controlled?
Yeah, she says maybe these pills that I'm taking are taking a bit longer. So that's why she said, well, come back in a month.
Because it takes 4 months. We say that after 4 months, you've gotten the full effect of Plaquenil.
So, yeah, if then I go back there and 4 months, it should be. Okay, 4 months. So I can calculate 4 months and then start not taking the cortisone. And if I still have these pains that, I'm taking 3 or 4 of them or 2 of them, then I can say, well, maybe then this is not quite working.
Absolutely. What's a little sad for me is that this is the job of the rheumatologist. And I know that in an insurance-based model, you don't have access to the rheumatologist that easily because they are talking to so many patients, right?
People, yeah.
But the thing that's really important to realize is that your, how do you call that? The goal is minimal disease activity / remission. All right. And if we can reach it with prednisone, then that means we can reach it with another medication that doesn't have side effects, that doesn't have the same side effect as a prednisone. And again, the goal is that we get you to full remission, and so then we can back off, right? And so if you're off of prednisone,
the other medicine that you said, meta something, that actually was offered to me. Yes, that was offered to me to read about the effects, and obviously I choose the other one, which is to start with low or with mild reactions, let's say, to see how it goes. But I had to take the cortisone in between, and then, for example, if with this medicine it controls the pain or it controls the inflammation, how long do you need to take it? So I don't understand that. For example, now in 4 months, she says, well, no, I'll better put you in the other one medicine that I asked you to read about, because this is not quite working. Then 3 months pass by. Yeah, exactly. And if in 3 months I feel better, then I should stop. Then I should start.
No. Again, the goal. So first of all, personally, if you were my patient, I would probably say, hey, you're clearly not in full remission. You still need the prednisone. And you clearly you said 2 hours of morning stiffness. You are not in remission. You are not in minimal disease activity. And this is I spend most of my time explaining to patients how they have not reached minimal disease activity. So why we should not be talking about stopping the medication when our goal right now is to reach minimal disease activity or remission. So for me, the way I would probably do it is if your insurance allowed us, I would put you on a biologic. And if your insurance doesn't allow us, then I would actually add the methotrexate. And so the reason for this would be, if on methotrexate plus Plaquenil, you're perfect, then we can try to decrease the methotrexate later on, right? Later on. We could try to decrease the methotrexate so that the only thing you're taking is the Plaquenil.
Which is the one I'm taking now.
Yes, but the thing that you're not realizing is, think of it like, let's say there is a fire. There's a fire. Let's say you have a field and there's a fire. You do not go with a drip of water to stop that fire.
Yeah, I understood that. Yeah.
You go with a hose, but to prevent the fire to come back, you could use a drip.
Mm.
And so that's the same concept. I could start with methotrexate Plaquenil, but with the goal later on to only have a drip and have just Plaquenil, right? That's the concept that you have to understand. It's like we start fast and we start big.
Mm.
Hose of the water.
That's the maybe she should have advised me a bit like that.
You don't
she didn't, but she just gave me the option to have one or the other. And then I said, well, I'll go for the less risky, for the less, all these effects that I was reading. I was like, well, okay.
I know. Well, again, the practice that I am in is very different because my goal for all of my patients is so that they have as much information as I know, so you can make the right decision for you, right? Mm-hmm. But if I tell you, if it were me, this is what I would do, like you'll be like, what? No, you have to understand everything before you can make a decision, okay? The other thing also, like just not, so that we don't throw her under the bus, is that you have already been on 4 months of Plaquenil. So it's easy for me to say, well, it's not working. Who knows, right? Like she didn't know at the beginning. And she didn't want to push you, which makes sense. She was like, well, hold on, like you're a little bit resistant in starting medication. So I'm not going to push, okay? Mm. But for me, the goal is full remission as fast as possible so that we can back off.
Yeah. So it could be that if I need the other medicine, it could be just for 3 months and then see.
No, I would at least do 6 months. I would at least do 6 months, if not a full year, depending on how you're doing. And again, so this is so important. We're talking if you tolerate the medication. Because if for whatever reason you do not tolerate the medication, we're not waiting, we're stopping that medication and switching to something else. Well, I have had so many people who would just like wait and suffer through a medication that doesn't do good for them and is like super awful for them. And I'm like, hold on, we don't have to wait the full 3 months if you do not tolerate this medication.
Yeah. Okay. So tolerating means that you need to try and see if your body,
Exactly. Like, how do you do with that medication? Are you doing well? And at the beginning, very often, for the first month, we are just evaluating the tolerance. Are you tolerating well the medication? Yes or no? And then after 3 months, in total 3 months, we evaluate, is it working? But the first month we evaluate, are you tolerating this? Yes or no?
Mm-hmm. Okay. Yes. I mean, I also, I've been taking omega supplements. That's another thing that she says is not very, is not proven. She doesn't know about. If I want to take them, probably they don't do anything, which is omega-3, some vitamin D, vitamin C, with collagen. I thought for the joints. I don't know. Stuff like that. For the liver, now I thought, well, I'm taking medication. Maybe my liver is going to suffer. I'm starting to...
No, don't. Our bodies are actually pretty incredible, and it makes me. Sorry, this is a story.
These supplements then that they really don't work, do they? I mean, I don't know. I just thought I was trying to help.
It's the same
my
thing.
Body.
It's it reminds me of my sister. I remember she was like making me laugh so hard because she was like, oh, you have to eat organic. She was like, I'm eating an organic. I don't touch this and no. And then I was like, wait, you're a smoker. And she was like, yeah. I'm like, okay, well, stop smoking. Then we can talk about diet and, all of the supplements. But the supplements in rheumatoid arthritis, there's a couple that may be working, but overall, so much less than all of our medication. Now,
curcuma I'm taking as well.
Curcuma does work. Yeah, no, curcuma does work. But here's the thing. We have so many good medication nowadays that the only thing that you should have that would remind you that you have rheumatoid arthritis is that once a week you're taking like, or maybe you're taking medication, but you're not taking that many. And then you'll be like, oh yeah, I forgot that I have rheumatoid arthritis. That is how it should be. This should not be living with you. And very often with supplements, I find that people have so many supplements that it's like, you have like this and that and this and that. And I'm like, hold on, like even I don't give you that many pills, right? So like, don't make your life about this. Like this does not define you. And we can take care of it so that it doesn't define you. Now, I want to share something that I think is really important. I was telling you about the stress and how stress affects rheumatoid arthritis. When we have, there is, an association of this autonomic nervous system. And what it is that there is a device that can actually stimulate the parasympathetic system. So there is a device that basically you're stimulating the vagus nerve. And so not that I'm recommending that, but I just want to say that there are studies that are showing that if you stimulate the vagus nerve right here by putting a device, you actually decrease the inflammation. And you can get our patients in minimal disease activity. And that is, to me, extraordinary because that is without medication, okay?
Yeah.
And so that, again, I personally wouldn't do a surgery, but you can stimulate the vagus nerve by doing meditation, by doing breathing, and so on, okay? So you could actually put your regimen every day. I'm going to do box breathing. Every day I'm going to meditate because that will stimulate your vagus nerve. You could also like just splash some cold water on your face. That stimulates the vagus nerve. So that's that. And then the second thing is I do think that people who are in full remission, if they work on their diet, if they work on the parasympathetic system stimulating the vagus nerve, we could potentially get those patients to not need medication by just stimulating the parasympathetic system. That's where I think that there is a role in this your life. But until you're in full remission, it's a little stressful to have rheumatoid arthritis. And to me, I'm like, well, we have amazing treatment. Why are you not taking those? Right? That's how I see it. Okay.
Yeah, because in the evening, I remember, no? I mean, actually, what you say about the smoke, I do sometimes. I mean, I've been smoking a little bit, but just in the evening, just at the end of the day. And also, I'm trying, to less, and also trying not to drink alcohol, for example, a beer or some wine. I'm trying also not to. Sometimes it's socially difficult, especially on these dates.
So I will tell you one thing that's important.
But at night also, I actually, when you said, is it more in the morning, is it at night? And last night, for example, my neck was really painful, my neck and my hand a little bit. So maybe at night a little bit as well. Or maybe it's because this medicine is not enough. I don't know.
And at night, I don't know that it's necessarily RA. It could be a little bit of osteoarthritis or muscle tightness. This is important, Martha. If you smoke, Plaquenil or hydroxychloroquine does not work as well. So you're actually you're taking a medication and you're taking something that stops the mechanism of Plaquenil.
Okay.
So I would, first of all, smoking is very inflammatory and causes rheumatoid arthritis. So that's something, instead of the supplement, and so this is important, stop the supplement if you want.
Moment, I'm on the phone.
Yeah.
Moment, I'm on the phone.
No worries.
Everybody's driving.
And the truth is that I get it. Like smoking is something that people do because they like it. I used to smoke, so I know how much I loved it, but it is very inflammatory. Now, I think probably, and I want to kind of wrap this up, but probably my recommendation would be, you are not in minimal disease activity. There is no reason for you to live like this. We have other treatments. As you can see, we switch every 3 to 4 months. And so I think we have other medicines that will probably work better. There is no reason to fear the side effect of a medication that you haven't tried. And so this is the thing that I say very often.
That's you're right. You're right. You need to try.
you try, and it's like dating.
Just
You
1
don't
month for the
marry
tolerance or not.
everyone. Exactly. Yeah. You don't marry everyone that you date. So you like a medication, you're dating them. It works, great. It doesn't work, you move on. Right?
Yeah.
And like that is like dating. So that's my recommendation. My recommendation is don't withhold the medication from you just because you are afraid and you're like, oh my gosh, I have RA. Is this forever? No, it doesn't have to be forever, but you need to treat it as fast as possible so that you are in remission as fast as possible. Okay?
Yes, it's been very informative and helpful, actually, the talk, because I didn't know, about, I mean, when you put this symbol of the fire, it's totally clear to me then.
Yeah. No, I love it. Well, but thank you for allowing me to educate other people in this video, because I think that the question that you're asking are that's like the question that a lot of people are asking is like, am I going to live with this in pain all of the time like this or not? And
because I was I'm very active person, and I used to do Pilates in the morning, stretchings, and now I'm just like, not doing it because
do it.
Because the hands are hurting or whatever, and I want to keep doing a lot of sports and stuff, so which I am very active.
Yes, do it, and don't let this define you. It doesn't define you, and I can tell you really for a fact, I don't think I know any rheumatoid arthritis patient who has not gone into full remission.
Okay.
And so it's just a matter of finding the right treatment for you. Okay. Don't fear the medication. It's like fearing meeting a new guy or a girl, like a meeting, like dating. It's like fearing dating. Dating doesn't mean anything. It just means you try. And then it works. You're like, okay, great, I'll marry you. And you can always divorce, right? So, but that is like, there is no attachment to anything. It's not like, oh, this is defining me. Oh, the way I'm feeling is forever. No. Okay. So yeah. All right. But thank you so much. Thank you. All right.
Thanks, Isabel.
Let us know how you're doing, okay? Let us know.
Yes, I will. Right. And have a nice end of the year.
Oh, yeah, you too.
Happy New Year, yeah?
Mistakes, okay?
We'll be in touch. Thank you so much. Bye.
Yeah. Bye-bye.
Well, thanks again for tuning into the Unabridged MD podcast. Be sure to subscribe so you can be notified when the next episode is up. And as always, if you think that this would be helpful for a friend or a family member, please share. Wishing you wellness. Until next time, take care.